Today's topic is menopause. This is Renyi MD. My pen name is Peter Eckhart MD. I've been using progesterone for 22 years. Okay, we have 30,000 patients. And here is a testimonial from an actual patient.
4 years ago, I had to have a hysterectomy due to a diagnosis of adenomyosis. And 1 year after I had that hysterectomy, I was having some pretty severe symptoms due to menopause. And that ultimately is what led me to Dr. Eckhart. But before that, many trips to my gynecologist to try to figure out how to handle going through menopause gracefully. At that time, I was experiencing what I would call some pretty drastic symptoms due to menopause. And why I would call it drastic is because it was significantly affecting my life. Everybody talks about hot flashes, so it wasn't just hot flashes, but I'll put it in there. Hot flashes, night sweats, sleeplessness, forgetfulness, and probably really, if I'm going to be honest, the worst part of it all was the dryness, the itching, and the walls of my vagina had become so thin that every single time I was intimate with my husband, no matter what precautions we took, the skin on my vaginal walls tore away. It was painful, and it was a really difficult time. So back to my doctor I went. She would prescribe HRT, whatever she could do to try to help me alleviate this terrible time in my life that was pretty much consuming me as a woman. But really nothing helped. And at that time, I was also doctoring because I had 3 areas in my breasts that had to be watched. And so I had a higher concern for cancer, the correlation between HRT and cancer, something I didn't want to aggravate any more than what was happening. So that led me to Dr. Eckhart, just honestly by the grace of God. I don't know, I had combed the internet 1,000 times to try to find another woman that was experiencing what I was, with really no luck. I don't know if it's embarrassment, I don't know what it was, if people just didn't feel strong enough about telling their story, but I needed help. So finding Dr. Eckhart was really kind of my last straw, I felt. That's where I was. I was hanging on to the very end of a rope and suffering a little bit from depression because of the change in me. And so when I found him, I thought, well, this is it. I'll try it. This is a natural way to deal with this. And honestly, I'm not trying to be exaggerant or I don't know, whatever word you want to put in there, but meeting him, using his products changed my life. And if I could, and I do, I tell every woman that I come across that might even feel remotely comfortable opening up to me about Dr. Eckhart, and I can't say it enough, is that by using his products and him telling me or helping me along the way, it changed everything. So no more hot flashes, no more night sweats, no more forgetfulness, no more tearing, and no more dryness, none. And all I had to do was, well, actually it's not all I had to do, it was quite an adjustment. I had to get rid of all products that I used, and I went solely off of his list that he provides when you order the Progesterone, and I ordered this, you can't see it anymore, estriol. And I used those 2 products. I changed my products and went solely off the list that he sends when you order a product, and everything changed. So that's why I'm here. I'm going to give this honest review. If you're like me and you're experiencing these things, if you're a doctor and you're going to come across a woman like me who's really at your mercy. These are the things that are going to make a difference in someone's life.
Okay, and that's kind of a typical patient for me. It's not my best patient, it's a typical patient. So the plan today is I'm going to give you simple ways for you to treat your patients. Okay, possible mechanism for hot flashes and night sweats. So 1, problem, menopause. Solution, avoid all xenoestrogens and no stress. No hormones are needed. So xenoestrogens are chemicals and herbs that act and mimic like frankenestrogen. Xeno just means foreign. Estrogen is estrogen. So these are frankenestrogens. Again, problem, vaginal dryness. Solution, transdermal natural progesterone. Problem, vaginal atrophy with tearing, itchiness, dryness. Solution, transdermal natural estriol or E3. Okay, we're also going to talk a little bit about cortisol steal, which will mess up your treatment. Okay, and you can also use ashwagandha. Okay. And also we're going to talk about high histamine foods. And again, I would, this is about the 4th lecture I've had. The first lecture I actually talk about avoiding xenoestrogens and also the treatment of most female disease. I suggest that you watch those lectures as well. So let's talk about the mechanism of hot flashes and night sweats. This is the best guess. Okay, and so here you have a woman here, and she has the hypothalamus. The hypothalamus releases gonadotropin-releasing hormone, okay? And then the pituitary releases luteinizing hormone, or LH, and follicle-stimulating hormone, FSH, okay? And then what happens is that the ovary makes estradiol, and that feeds back to the hypothalamus, okay? So what happens is after menopause, estradiol is reduced because there are no more eggs, and when there are no more eggs, no more ovulation, okay? And estradiol is reduced, okay? And so since estradiol is reduced, okay, the shouting hypothalamus begins to release more gonadotropin-releasing hormone, and it's affecting the adjacent vasomotor nucleus, vasomotor center called the arcuate nucleus. Okay? And the hypothesis that night sweats and hot flashes because of the increased shouting gonadotropin releasing hormone. Okay? In most cases, it is the change of hormones, not the absolute value, that's creating the hot flashes. So this is really important to remember. It is the change of hormones, not the absolute value. Okay, you get the mood swings, the fatigue, the cold, the strange stress response to stressors. Okay, so let's look at this for a normal American woman with 2 children. Again, here's premenopause. Okay, so after age 35, you have perimenopause. And then after the age of 55 or 60, you have aftermenopause. So premenopause, before the age of 35, okay, you have 100% estradiol and 100% progesterone. After the age of 35, you're having anovulatory cycles, meaning you do not ovulate. And again, I've covered this in previous lectures, so make sure to watch the previous lectures. What happens is even though you're cycling, you're having a menstrual cycle, you're not ovulating. And if you don't ovulate, you don't have a corpus luteum. And then if you have no corpus luteum, you have no progesterone. So typically if you're after the age of 35 and you do a progesterone level, the progesterone level will be very small, less than 1% of normal. Okay, because you're not ovulating. You're having a cycle, okay, but you're not ovulating. So before the age of 35, the follicle comes up, pops out an egg, the used follicle becomes a corpus luteum and begins to produce progesterone. That's why before the age of 35, you're making a lot of progesterone. But after the age of 35, what happens is that the follicle comes up and goes back down. No corpus luteum is produced since no egg pops out of the follicle. And therefore, if you have no corpus luteum, you have no progesterone. Okay? After menopause, again, you have no progesterone or very little progesterone, and then your estradiol levels drop to about 60% of normal, okay? But it doesn't go to 0 because the fat cells in a woman produces estradiol. In fact, A fat woman after menopause will produce more estradiol than a skinny woman before menopause. So the fat cells produce estradiol. Okay, so how do you deal with menopause? I'm going to tell you the simplest way is just avoid xenoestrogens and stress, and then you avoid the bad menopausal symptoms. Okay, so John Lee, MD, believes that women in third world countries have little xenoestrogens. They do not eat processed food. They eat lots of fruits and vegetables. Okay, my wife and I eat whole foods, whole fruits and vegetables for the last 20 years. We avoid all xenoestrogens in the house. Okay, no xenoestrogens in the house. My wife is 58 years old. She never used progesterone prior to menopause. Okay, when she did go through menopause, she had a little bit of hot flash, a little bit of night sweats for a month. She used a little bit of, progesterone, estriol for a couple months, and then slowly tapered off. And after that, she was kind of normal. Okay, so she just used progesterone, estriol for a couple months. That was it. Okay, so this is the simplest way to deal with hot flashes and night sweats. Right? Don't eat all these processed foods. Eat a lot of whole foods and vegetables. Avoid xenoestrogens. Don't have a lot of stress. Okay? So let's talk about the role of stress in menopause. Okay, I was in Colorado. This is about I want to say 12 years ago. Okay? And I went to church, and this lady talked to me. She has hot flashes. So I gave her a free bottle of progesterone. Okay? And I saw her a month later, no hot flashes. And I was kind of patting myself on the back saying, hey, did you notice when you took the progesterone you have less hot flashes? And she goes, I never used the progesterone. Okay. We just went to Maui, my husband and I, for a month, and the hot flashes disappeared. So again, we're talking about the cortisol steal. Okay. You have cholesterol at the top, mixed pregnenolone. Okay. Progesterone. And then progesterone makes cortisol, and on the left-hand side you have estrone and estradiol and estriol. Okay, so when you have fear, stress, anxiety, your body to deal with that, either physical or psychological stress, tries to produce more cortisol to deal with the stress. And if you have a lot of stress, it'll steal away from progesterone, and it'll keep on stealing away from that end of the branch until you don't have very much estradiol, estriol, and progesterone. And guess what? You're going to have hot flashes because your progesterone levels your progesterone levels are always -1, but very small, but you're not going to have very much estriol or estradiol because the cortisol is eating up all the estradiol, estriol, and estrone. Okay, so one solution is to take transdermal progesterone. Okay, Leonetti, double-blind study, 102 women, 20 milligrams of transdermal progesterone a day. Okay. You can take it anytime you're not having a period, or you can take it 3 weeks out of 4. The progesterone wakes up the estrogen receptors, making your own estrogen more effective. Okay. Also, the progesterone can be used for vaginal dryness. All right. So, it was improvement or resolution in 83% of the women with vasomotor symptoms versus 19% of placebo. A Norwegian study in the journal Marietta showed low testosterone, low DHE, low estradiol, high FSH was associated with hot flashes. Progesterone was not measured because it's probably 0 or close to it. Okay, high testosterone predicted recovery from hot flashes 1 year later. Okay, so maybe there were the people who had low testosterone, they had a cortisol steal. Okay, progesterone supplementation may indirectly increase testosterone and estradiol. Okay, also increases estrogen receptor sensitivity. Okay, so again, if you give progesterone, right, they're able to make more cortisol, and the progesterone can make more testosterone and estradiol, right? So progesterone is in the top of the hormone cascade. So you're kind of, to deal with the stress, okay, you're kind of adding more progesterone so they can make more estradiol. And the progesterone, estradiol, kind of decrease the hot flashes because it feeds back to the hypothalamus and that whole cascade, and then gonadotropin releasing hormone. You don't have to shout anymore with that, and the hot flashes and night sweats go away for 83% of the patients. We're going to cover those 17% that it doesn't work. We're going to cover that later in the lecture. Okay, so let's look at the Women's Health Initiative in 1991, the WHO federally funded study. Okay, and what they did is they compared Prempro, which is Premarin horse estrogen plus Provera. Can anybody tell me what Prempro is? Premarin horse estrogen? Yes, it means pregnant mare's urine. Okay, so what they do is they get horses, they get them pregnant, okay, And then they have these pregnant horses that are standing in the stall, and they collect their urine, and they get the hormones from that urine and use it as Prempro. So if you take a Prempro capsule and you crack it open and smell it, it smells like urine. Okay, so Premarin is horse estrogen from the urine from pregnant mares. Okay, and it's still done that way, plus Provera. So that's one thing of how to do it. Okay, and after 5 years, 16,000 women, 50 to 79 years old, at a 29% higher risk of breast cancer, 26% higher risk of heart disease, and 41% higher risk of stroke. This arm was canceled after 5 years, 3 years early, because of this poor outcome. So let's compare Prempro to estradiol. On the right, you have bioidentical estradiol. This is the same hormone that your body produces. Okay. On the left, you have Prempro. Okay. Prempro is made from estrone sulfate, 50 to 70%, and equilin sulfate. Okay. And again, if you look at that molecule, it is not the same that your body produces. In addition, Prempro contains 230 other steroidal components because they take the horse urine and then they purify it. You can still smell the urine in the Prempro, okay? And that Prempro contains estrone, equilin, and 230 other steroidal compounds, okay? Let's compare Provera versus progesterone. So medroxyprogesterone causes birth defects. And again, natural progesterone, bioidentical natural progesterone, that stops miscarriage in the absence of abortifacients. Okay, you look at that molecule. Okay, and it's somewhat similar to the one on the left, but again, it's different. Okay, if you look at it, there's an extra O on the very right hand of the molecule. In medroxyprogesterone, it's in red. Okay, and this molecule, medroxyprogesterone, is different from natural progesterone. So again, medroxyprogesterone causes birth defects, but bioidentical natural progesterone stops miscarriage and abortion in the absence of abortifacients. Again, fertility MDs use bioidentical natural progesterone to prevent miscarriage and safeguard the pregnancy. But if you use medroxyprogesterone, that would be considered to be malpractice because it causes birth defects. So natural progesterone does not cause birth defects, and medroxyprogesterone causes birth defects. Why? Because the two molecules are different. Okay, today, right now, this slide, we're going to talk about a very controversial subject, and I really apologize for that. You will find it, this is from the first edition of What Your Doctor May Not Tell You About Menopause by John Lee, MD. But the second edition, it is missing. And the reason why it is extremely controversial. Again, I'm sorry for this. Some people are going to get mad at me and start criticizing me. I apologize. I'm sorry. Okay, again, it was taken out of the second edition of What Your Doctor May Not Tell You About Menopause, so you'll not find it in the second edition, but you will find it in the first edition. Why? Because it makes a lot of people upset. So I want to apologize in the very beginning, okay? But again, I think it's important that we go over this data because as a physician, you need to know why things are. So basically, the statistics were manipulated, okay? In the 1991 New England Journal of Medicine, Estrogen Heart Disease claims that from the Nurses Health Questionnaire Study, from 76 to 86, 121,700 female nurses, 48,470 postmenopausal, okay? Were given questionnaires every 2 years, and the nurses reported on it. Okay, there are 20 studies using estrogen risk that says that the risk of coronary disease, the results were debatable. The Framingham study showed no coronary benefit. Others showed increased risk. Okay, but the Nurses Health Questionnaire study, the deaths were only 2.6%, so there's a question of whether that was statistically even significant, but this is how it was. Basically, in the Nurses Questionnaire study, okay, the healthy nurses were not taking hormones, but the sick nurses were not taking hormones. They were the control group. Okay, so all the sick nurses were in the control group. Why? Because these are nurses. And the nurses kind of knew that the synthetic estrogen causes clots and heart disease and strokes. And so if you were sick and had some kind of risk factor, you didn't want to take the hormones. Okay? So again, this is the table from the original paper. And again, I just want you to concentrate on the two columns here. One is the current users of synthetic hormones versus the people who did not take hormones. Okay, so on the left-hand side, you can see that 2.7% of the people had diabetes. Okay, and the ones who did not take hormones, 3.5% of them had diabetes. So basically, the control group, they had 29.6% higher, no hormones. The ones who took no hormones, they were smoking more. Okay, 30% of them, right? Current smoker. The body fat was 53% higher than the people who were taking no hormones. There's less exercise than the people who were taking no hormones. All the sick women were not taking hormones. The fake conclusion was that postmenopausal women reduced the risk of heart disease, okay, taking estrogen. Okay, there's a big marketing push. So why would the people that wrote this paper, why would they try to mislead you? And the answer is that Prempro sales were $2 billion in 2001. And then when the WHI study came and showed that Prempro causes a lot of these cancers and a lot of these strokes and a lot of these coronary artery diseases, physicians took note of that, and sales dropped from 2 billion to 880 million. So the reason why people would do that and mislead you, putting all the sick people in the control group, is because of $1.1 billion a year. Okay, so let's look at bioidentical estrogens made by the body. Okay, let's look at estriol. Estriol is known as E3. It's weak, and it's associated with protection from breast cancer and uterine cancer. Okay, let's look at now estrone. Estrone, known as E1, is considered to be weak and associated with breast cancer. Let's look at estradiol. Okay, it's strong and responsible for the breasts and hips, and it's associated with breast cancer. So your body makes 3 kinds of estrogens. Your body makes 1 kind of progesterone called progesterone. All right. And the one that's associated with protection from breast cancer and uterine cancer is estriol, or E3. So let's look at postmenopausal estrone and estradiol linked to breast cancer. In postmenopausal women, increasing circulating concentrations of estradiol, estrone, estriol, estrone, and estrone sulfate, and androstenedione have been associated with a higher breast cancer risk. This is postmenopausal, remember. Okay. High levels of sex hormone binding globulin have been associated with lower risk. Again, from the previous lecture, you know that the estradiol, okay, and that's bound to the sex hormone binding globulin. That's the inactive form. Okay, the free hormone that's not bound is the active form. So this makes sense. The higher level of sex hormone binding globulin that's bound to estradiol, okay, the higher level you have has been associated with lower risk in postmenopausal women. Okay. Dr. Ercole Cavallari, University of Nebraska Cancer Research, discovered the metabolic steps to convert estradiol and estrone, but not estriol, into DNA mutating catechol estrogen quinones, leading to breast cancer. Okay, premenopausal, people before menopause, women with estradiol and estrone are not linked to breast cancer, probably due to the progesterone being present. Okay. In premenopausal women, cancer and nutrition, the EPIC cohort, okay, the Guernsey cohort, the Rosenberg studies had larger sample size of 285, 62, and 79 cases accounted for the phase of the menstrual cycle. No statistically significant results between breast cancer risk, estrone, estradiol, or sex hormone binding globulin. In 2011 meta-analysis of those 7 nested case control studies, a total of 693 cases and 1609 controls, there was a weak relationship between circulating estradiol and breast cancer risk was reported. But early follicular blood samples from breast cancer cases, N197 in Nurses Health Study, and NHS2 demonstrated a significantly elevated breast cancer risk in women with higher total free estradiol. No evidence of relationship between breast cancer, estrone, and estrone sulfate or sex hormone globulin was seen. Okay, so why is it that estradiol, estrone, okay, are not associated with breast cancer, okay, premenopause? Probably because of progesterone. Okay, so let's look at this graph right here. Okay, and this kind of explains it all. Okay, on the y-axis you see the number of mitoses per 1,000 cells. So you're looking at your breast cancer cell, okay, and on mitosis you're looking for division. So the higher on that y-axis, the more cells are dividing. Okay, the first one, okay, so these women in Taiwan, they applied cream on their breasts 10 to 13 days before surgery for breast lumps, for breast cysts. Group A was a placebo. Okay, Group B was 25 milligrams per day. Group C was estradiol, 1.5 milligrams per day. And Group D was progesterone cream, 12.5 milligrams a day, with estradiol, 0.75 milligrams a day. So what you can see here is placebo, okay, that's 0.5 mitoses per 1,000 cells. And you give them progesterone, all of a sudden the cells stop dividing. But you give them estradiol, and all of a sudden they're dividing more. But you give them estradiol plus progesterone, and again you see the number of mitoses come back to normal, the placebo. So this kind of argues for estradiol makes them proliferate, progesterone stops them from proliferating, and estradiol with progesterone for those concentrations became normal. The progesterone kind of stopped the action of estradiol from making them proliferate. Okay, so why is estradiol and estrone not associated with breast cancer in premenopausal women? Likely because of progesterone. Okay, so that's it. Estriol goes high during pregnancy. Well, here you have estradiol, estrone, estriol. Okay, and estriol goes high during pregnancy. Women that are pregnant deliver 9 times have a smaller chance of breast cancer and endometrial cancer. So this means probably estriol is good for you. Okay. Sex drive goes high during second and third trimester, most likely to high progesterone, estriol, estradiol, and estrone levels. Estriol thickens the skin of the birth control canal so that birth canal does not rip. Weak estriol blocks strong estradiol. This is why boy and girl babies look kind of the same. Okay, the reason why boys end up looking like girls is from the mother's estradiol is the estriol is a weak estrogen. Estrone is a weak estrogen and blocks the strong estradiol. Only estriol is protective for breast cancer. Major large peer-reviewed trials, topical vaginal estriol does not increase the risk of breast cancer. The Million Women's Trial, Fournier, Rosenberg, Whiterpass. Whiterpass found that oral but not topical estriol caused breast cancer, suggesting progesterone use. Rosenberg found that topical estriol found no association with any breast cancer. Okay, Dr. Greenblatt, prominent hormone researcher of the 1980s, believes, quote, estriol relieves hot flashes and prevents vaginal dryness without side effects. Dr. Wolf Utian, editor of North American Menopause Society's journal Menopause, stated, estriol has the potential of reduced risk but similar benefits to alternative estrogen or estrogen progesterone formulations. The potential to minimize risk yet maximize most benefits places estriol in the unique category among estrogens. Okay, so the take-home lesson, okay, topical estriol alone in therapeutic amounts does not cause breast cancer. If you're going to use estradiol or estrone, make sure you use progesterone with it to avoid breast cancer. Personally, I prefer using topical estriol and progesterone. Estriol benefits, okay, postmenopausal, vaginal atrophy, bleeding on intercourse. Okay, vaginal atrophy is reversed. The vagina kind of shrinks. That won't help. The progesterone won't help. Estriol won't help that. But the bleeding on intercourse, it'll thicken up the skin there, and the ripping of the skin on intercourse, that is prevented by using estriol. Urinary stress incontinence can be reduced by using estriol. Hot flashes and night sweats are reduced by using estriol. Estriol does not increase the risk of blood clots. It treats acne scars. You can use it on the face. In a 1996 study in the International Journal of Dermatology, precise objective testing measurements skin vascularization, skin elasticity, firmness, moisture content, wrinkle depth, and pore size showed improvement of 73 to 100% of women using estriol cream for 6 months. Skin samples showed increased type 3 collagen. Estriol benefits? Well, in 1987, Dr. Lorzan showed that estriol relieved menopausal symptoms in a 5-year clinical trial of 2 milligrams of oral estriol succinate in 940 post-menopausal women. Estriol was shown to protect against cancers of the breast and uterus. In 5 years, 2 breast cancers developed, 3 expected, and no endometrial cancer developed, 3 expected. Dr. Lemon ran a clinical study of 28 breast cancer patients, 2.5 to 5 milligrams a day of oral estriol therapy. Estriol induced remission or rest of metastatic tumors in 6 women, 37%. In a 1975 article in Cancer Research, Dr. Lemon stated that 2.5 to 5 milligrams per day orally might be suitable for a minimum dose to prevent breast cancer. Pregnant women excrete 30 to 50 milligrams per day of estriol. So you can probably increase the estriol up to 30 or 50 milligrams and still be safe. The take-home lesson, topical progesterone, 20 to 60 milligrams a day, every day, or divided BID, once a day or divided every day, okay? Divided twice a day, rather. And then I usually give topical estriol 0.5 to 1 milligrams every other day, okay, for the first 10 days to preload them, and then every other day, okay? Because it has a long half-life excretion, so you have to do it every other day. 3 weeks on and 1 week off indefinitely, or you do the 1 week holiday to prevent downregulation of the progesterone and estrogen receptors. Or you can continuously use it and slowly taper it off in 1 year. So you can do the 3 weeks on and 1 week off indefinitely. Okay, so here's the problem. The person has hot flashes. You give them topical progesterone estriol, and it doesn't work. Okay? And they have a hypersensitive to smell, a positive Romberg, seasick, and a small bone in the ocean, and sensitive to drugs. So I covered this in the previous lecture about how to treat female disease. I cover this. And these people who are hypersensitive to smell, positive Romberg, seasick, and a small bone in the ocean, they're very sensitive to drugs. These people usually have fear, stress, anxiety issues. Okay? And when they have fear, stress, anxiety issues, guess what? They're anxious and stressed, and they're trying to produce a whole bunch of cortisol. And because they're producing so much cortisol, their postmenopausal serum estradiol is less than 5, or 10, when you would usually expect 60 or 100. Okay, you're seeing something where they got nothing at all, and they got hot flashes out the wazoo. They are absolutely freaked out, okay? They have massive hot flashes. So why? Because there's a cortisol steal for the progesterone. There's a cortisol steal happening, and they're making so much cortisol that they can't make any estradiol at all. Okay? So, but you could increase the estriol to stop the hot flashes. Why? Because the cortisol steal will not affect your estriol levels. Okay, so there is no cortisol steal for estriol. Okay, so let's look at this again. The hot flashes cortisol steal. Let's look at a more detailed synthesis of what your body does. Okay, so here up at the upper left-hand corner, from cholesterol, you make pregnenolone that goes into progesterone on the left-hand side, going down the column, and finally you make more cortisol. Okay, and again, the physical or psychological stress increased cortisol, stealing away from progesterone, estradiol. So again, you make pregnenolone, right? You give them progesterone, and you're just making a whole bunch of cortisol because they're freaked out. So guess what? No more estradiol, no more estrone, okay? And so what happens is that, but you look at estriol, okay? Estriol is not reduced by cortisol steal. So if you just give them estriol, okay, it doesn't, you see that arrow? It's a one-way arrow. There's a two-way arrow between estrone and estradiol. That's why they think estrone gets converted to estradiol. That's why estradiol is linked to breast cancer. So you give them estrone that could lead to breast cancer, okay? But again, if you go to, estrone is synthesized to estriol, okay? And you cannot make cortisol from that. So if I give them progesterone, they make more cortisol because they're stressed out. Progesterone levels go to 0, okay? Again, and then if I give them estriol or estradiol or estrone, there's a one-way arrow down there, okay? And it doesn't, even if they're stressed out, it doesn't reduce it. So if I give them estriol, estradiol, okay, it doesn't affect them, okay? But again, the progesterone levels will go to 0, okay? So I like to give estriol because there's no back arrow. It doesn't convert, estriol does not convert to cortisol, okay? It just is an end metabolism right there. So if you have someone who's extremely stressed out, you measure the estradiol, it's less than 5 or 10, give them estriol, and that will sometimes take care of their rip-roaring hot flashes. So you may have to increase their estriol above 0.5 to 1 milligrams. Okay, so the conclusion to the cortisol steal, you can increase the estriol, tiptoe up in the dose. Estriol is not subject to cortisol steal. 1 day of third trimester estriol production is 35 to 45 milligrams. You can go up on that. Ashwagandha is also used in Asia. I don't have a lot of experience with that. And some people who have had this cortisol steal, rip-roaring hot flashes, I give them ashwagandha and they go, yeah. The hot flashes, night sweats do decrease somewhat with ashwagandha. Okay. In one study, in 98 chronically stressed adults, double-blind study, ashwagandha had significantly greater reductions in cortisol compared with the control group. Highest dose is 250 milligrams BID, and they experienced a 30% reduction on the average. Okay, I also sent them to a church seminar to get rid of the fear, stress, anxiety at beinhealth.com. They try and get rid of the fear, stress, anxiety. Okay. Some people, if you look at some of the progesterone creams on the market, they give lavender or rosemary, and the lavender or rosemary is a phytoestrogen. Again, lavender or rosemary is not subject to cortisol steal, but I don't like using it because of the increased risk of breast cancer from lavender or rosemary. Okay, I've also found that high histamine foods, some women have high histamine. It's a high histamine intolerance that's triggered by menopause. This is not an allergy. Some of these foods include alcohol, fermented beverages, fermented foods, yogurt, sauerkraut, dried fruits, avocados, eggplant, spinach, processed or smoked meat, shellfish, or aged cheese. Okay. So again, that's kind of it for hot flashes and night sweats. Not too bad to treat for most people. Okay. I'm going to talk about osteoporosis. I don't have a lot of clinical experience of this. Out of the several thousand postmenopausal patients I've treated, I've only seen 1 or 2 people get rid of their osteoporosis, and I just don't treat this a lot. This is from a more, this is a book report portion of the lecture, okay? So again, here you have a bone mass density. Anything on the y-axis, you have bone mass going from 0 to 1.2. Anything above 1.9, you're not going to get a fracture. Anything below 0.9, you're going to start to have fractures. And basically, this is a schematic bone graph of bone mass relative to age, okay? And if you look at this, okay, at age 35, it peaks, and then as you begin to lose progesterone, the bone density starts to decrease when you have decreased progesterone at age 35 to 50. And then at age 55, when you have decreased estradiol, you have massive decrease in bone density, okay? So again, I haven't seen a lot of luck with this, and it's because, so again, if you give progesterone, this is from John Lee's book, and again, I don't have a lot of clinical experience with this, okay? You can see here is serial bone density from 82 to 85, okay? And he's giving transdermal progesterone, a patient who's age 72, and you can see he's actually increasing bone density. And again, I've seen this happen in 1 or 2 patients, but not a lot of my patients. I don't usually do this with my patients, okay? So basically, according to Russ Jaffe and a lot of, he's an MD, PhD. He's the youngest fellow at NIH. Basically, bone density has decreased compared to several hundred years ago. The primary cause is an acid-alkaline balance. If you look at bone density of women normalized for age, compare those women's bone density in the church graveyard in the 1800s compared to bone density of American women today, you'll find that normalized for age, the bone density of a woman 200-300 years ago was much greater than the bone density of a woman today. And the reason why is of this acid-alkaline balance. And in America, we're too rich. We eat too much meat and too much sugar, and all these things are acidic. So if you take a in a simplified manner, if you take a chicken bone and put it in vinegar, it becomes soft after a couple weeks. So the body, in order to balance out the acidity of the too much meat and too much sugar, amino acid, right, as meat, what happens is you draw the bone density out of the bones to balance that acidity. So if you become more vegetarian and do the pH of your urine and try to alkalinize your body, or take baking soda, okay, to alkalinize your body. You can take it orally. Just make sure you don't take it during a meal, because then you'll deacidify your meal, and then you'll have malnutrition, because your body doesn't have acid in your stomach, and they have all kinds of other problems as well. Then you can, along with progesterone, you can increase your bone density. Okay, but again, I have limited clinical experience with this. Okay, so you can use baking soda, 1 teaspoon a glass of water, maybe 5 times a day. Proton pump inhibitors like Tagamet will like screw up your digestion. You have malnutrition and have bone density. Decreased salt intake will mean there's no HCl in your stomach, and then they'll have malnutrition. Diuretics will increase your mineral excretion. If you have antibiotics, you're taking vitamin K, you'll destroy your vitamin K, and that'll destroy your bone density. Take probiotics. Fluoride and strontium, even though you increase bone density, that's defective bones, so I wouldn't suggest doing that. Metabolic acidosis from cigarette smoking, again, would decrease your bone density. Alcohol abuse would again decrease your bone density. If you have excess L-thyroxine, okay, taking thyroid hormone, that'll also decrease your bone density. Corticosteroids will do that as well. Depo-provera will also cause a decreased bone density. Okay. So in conclusion, no xenoestrogens and no stress means no hot flashes and no night sweats. Topical progesterone can help with 83% of hot flashes and night sweats at 20 to 60 milligrams a day. Topical estriol protects against breast cancer, endometrial cancer at 0.5 milligrams to 1 milligram every other day. Only topical estriol does not lead to breast cancer. Okay. Topical estriol can help with vaginal atrophy, urinary stress incontinence, wrinkles on the face, bleeding on intercourse, postmenopausal UTIs. Estriol will not help with vaginal shrinkage, but will help with all the other issues. Okay, estradiol levels at less than 10 picograms per gram indicate a cortisol steal. These patients are usually anxious with a hypersensitivity to smell, seasick on a small boat, sensitive to small amounts of drugs, and have a positive RON burn. Then give progesterone estriol. You can tiptoe up dose for estriol. 1 day of third trimester, estriol, you're excreting 35 to 45 milligrams a day. So estriol has quite a wide range of therapeutic use. I usually start at 0.5 to 1 milligrams a day. If the person has rip-roaring hot flashes and night sweats, the estradiol level is very low at 5 or 10 or less than 5. You can start creeping up on the estriol and see if that works for their hot flashes. You can also give them ashwagandha to help with fear, stress, anxiety. You can avoid giving them high histamine foods to help with these patients. So again, here are the notes.